So good morning. So today myself Dr. Amit going to take a lecture on bone loss patterns in periodontal disease. So what exactly is a bone loss? When there is a inflammation of the gingiva, we completely heard that there is gingivitis which leads to periodontitis. So we are going to cover the topic today under introduction, etiology, factors determining the bone morphology and the bone destruction patterns. So what is the etiology of bone loss? Why that bone loss when we say that there are certain time horizontal bone loss, vertical bone loss, and there is a bone loss and there is periodontitis when we say eventually why that bone loss is there? What are the reasons for that? So first and foremost reason is extension of the gingival inflammation. We all are well versed with that gingivitis is an inflammation of the gingiva. When that inflammation spreads to the deeper tissues, that is periodontal ligament and the bone, so that is called bone loss. The second is trauma from occlusion. When there are any abnormal forces, they compress the periodontal ligament and the surrounding bone, that leads to bone loss. And the third is bone loss related to the systemic disease. In today's lecture we are going to discuss this one by one. So first is extension of gingival inflammation. The most common cause of bone destruction in periodontal disease is extension of inflammation from the marginal gingiva into the supporting periodontal tissues. Periodontitis, as it is the name suggests, it is inflammation of the supporting periodontium, is always preceded by the gingivitis, that is inflammation of the gingiva. But not all the gingivitis progresses to periodontitis. So the transition from gingivitis to periodontitis is associated with changes in composition of bacterial plaques. The recurrence of episode of acute destruction over time may be one mechanism leading to progressive bone loss in marginal gingivitis. The extension of inflammation is modified by the pathogenic potential of plaque or resistance of host. What does that mean? Either your plaque has become more pathogenic or the host, the resistance of host, the immunity of the host has been reduced. So what are the factors from the host? That is degree of fibrosis of gingiva. If the gingiva is nicely fibrotic or it is good, healthy, so it will not spread to the deeper tissues. Width of the attached gingiva. That is same thing. If you have a more width of attached gingiva, that means the gingiva is firmly adhered to the underlying bone. If that width is more, so the inflammation takes longer time to spread to the deeper tissues. And more so the peripheral reactive fibrinogenesis and the osteogenesis process. Continuation formation of fibers as well as the bone leads to lesser spread. Now there are two ways. One way, like the inflammation from gingiva, it passes on to the cortical bone and then it spreads to the periodontal ligament. And in the interproximal areas, you will see that it can directly spread to the interdental bone and then it spreads to the periodontal ligament. Now after inflammation reaches the bone, by extension from the gingiva, it spreads into the marrow spaces and replaces the marrow with leukocytic and fluid exudate, new blood vessels and proliferating fibroblasts. Now, the multinuclear osteoclasts and mononuclear phagocytes increase in the number, which lined up the house-shaped lacunae. In marrow spaces, the resorption proceeds, causing the thinning of surrounding bony trabeculae and enlargement of marrow spaces, and eventually there is destruction of entire bone and reduction in the height of interradicular bone. Now there is a very important concept that is called radius of action. What is that? Now it is like 1.5 to 2.5 mm, within which bacterial plaque induces loss of bone. Now if the thickness of a bone, what is the significance of this funda, like the radius of action? When you say there is an interradicular bone, the thickness of interdental bone is thin. The interdental septum is thin, which is in the range of 1.5 to 2.5. So most of the time you see that there is a horizontal bone loss in the interdental areas. And then eventually when the thickness of bone is more than that, so the radius of action is 1.5 to 2.5. If thickness of bone is more than 2.5 mm, we will see a angular bone defects there. Now interproximal angular bone defect can appear in spaces that are wider than 2.5 mm because bone marrow spaces would be destroyed entirely. Now, the bone loss or the periodontal progression is not a continuous process. So, there are periods of destruction and there are periods of rest. Now, there are bursts of destructive activity associated with the subgingival ulceration and acute inflammatory reaction, resulting in rapid bone loss. Now, the bursts of destructive activity, they coincide with the conversion of T lymphocyte lesion to the B lymphocyte lesion. Now, exacerbation, that means the same, the phases of activity when the destruction is happening are associated with loose, unattached, motile gram negative and anaerobic flora. So basically when you say there is a destruction is going on, you will see all the negative features, that is there is a loose, unattached, motile gram negative bacteria which is inhabiting the flora, the pocket. Or when there is a period of remission, that the destruction has slowed down or it is negligible, that coincides with the formation of dense, unattached and non-motile gram positive flora with tendency to mineralize. Now, tissue invasion by one or several bacterial species is followed by an advanced local host defense that controls the attack. Now, what are the various mechanisms by which bone destruction happens? The factors involved in the bone destruction in the periodontal disease are bacteria and the host mediated. So both the factors. So one, that bacteria is more pathogenic and it evades the mechanism, and at the same time host mediated. What does that mean? The factors which are released by the host. So that's why we sometimes say inflammation is a double-edged sword. So the factors itself released by the host, which doesn't differentiate between the host cell and the pathogenic cell, so it leads to destruction. Now the several host factors released by inflammatory cells are prostaglandins, interleukin 1 alpha and beta, tumor necrosis factor. Now the bone formation in periodontal disease. There are areas of bone formation are found adjacent to the areas of bone resorption and along the trabecular surfaces at a distance from the inflammation. So because of this, certain times you will see a thickening of the bone on one side and destruction on the other side. This thickening is known as buttressing bone formation. Now, there is intermittent bone formation and there is a destruction. Now that was related to the extension of inflammation to the deeper tissues. Now coming to the bone destruction caused by trauma from occlusion. So this happens sometimes because of the trauma can produce bone destruction in absence or presence of inflammation. What does that mean? When there is an absence, like the tissues are healthy, there is no pathogenesis per se of gingiva or periodontal ligament, purely because of the traumatic occlusal forces that leads to destruction of the bone, which we usually call as a primary trauma from occlusion. And then there is presence of inflammation, that already tissues are compromised on that when there is a trauma. Certain times the normal occlusal forces also act as a trauma when the periodontium is already weakened. So that is called secondary trauma from occlusion. Now in the absence of inflammation, the changes are caused by increased compression and tension of periodontal ligament and alveolar bone, and because of this increased osteoclasis of alveolar bone, which leads to necrosis of periodontal ligament and leads to resorption of bone. These changes may cause angular bone loss, whereas in the presence of inflammation, the changes cause bizarre pattern. There are different patterns when there it is because of inflammation or because of the bacteria. Now the third factor was bone destruction caused by systemic disorders. Now the systemic influence on the response of alveolar bone has been termed as bone factor in periodontal disease. So there are certain systemic diseases which affects the alveolar bone or the bone supporting the tooth. So that leads to destruction of that. Now first and foremost is relationship between periodontal bone loss and osteoporosis, which is a physiological condition of postmenopausal women resulting in loss of bone, mineral content and structural bone changes. Bone loss may also occur in generalized skeletal disturbances like hyperparathyroidism and leukemia. Now, there are various factors which affects the bone morphology in periodontal disease. First is normal variation in alveolar bone. Certain times the normal variation of bone, certain times we have a ledges, right, tuberosities, or certain times we have a certain big chunks of bone which is like on present on the mandibular and the maxillary structures, which we say is mainly exostosis of the bone. Then trauma from occlusion, then buttressing bone formation, the food impaction also, because of the food impingement, food impacted within the deeper tissues, it leads to the bone destruction there. Then juvenile periodontitis. Now there are various bone loss patterns. The first and foremost is horizontal bone loss, which I prescribed, like I already said that when there is a radius of action is 1.5 to 2.5 mm, and the width of the bone is within that range. So bone, if it is within the range of 1.5 to 2.5 mm, we will see mostly horizontal bone loss. So it is the most common pattern. It occurs when the path of inflammation is to the crest of the bone. Remember, initially I said that there are two paths. First is directly to the crest of the bone, that is mostly in case of interproximal bones, right? The crest of the bone is perpendicular to the tooth surface. So now usually it is a triangular, the interradicular bone, but once that triangular part is gone and the bone width until it is more than 2.5, we will see a horizontal bone loss, and mostly this kind of bone loss produces a supra bony pockets. Next is vertical bone loss. When does it happen? It is a less common pattern. It occurs when the pathway of inflammation travels directly into the periodontal ligament space. So it doesn't go through the crest of the alveolar bone. Directly from gingiva, the inflammation spreads to the periodontal ligament, and there it causes a angular bone loss. So the destruction starts from the inner surface of the alveolar bone. This type of bone loss produces infrabony pockets. It occurs interdentally, which we can see on the radiograph. Now these vertical bone losses are further divided into different categories depending upon the type of bone loss. What is that? We have a three-wall defect where the three walls are present in particular surface, and it is two-wall defect when one of the wall is entirely destroyed. So we have two walls present, either a facial or a lingual plate is gone. And thirdly, we have one wall defects. What are they? When both facial and the lingual plates are gone and there is a destruction of interproximal bone. So one wall is left. So this is also known as hemiseptum. Now next most common is osseous craters. Osseous craters are concavities in the crest of interdental bone confined within the facial and the lingual walls. So it is like a concavity. You have a facial wall and a lingual wall at a higher level, and the interproximal bone has been destroyed, and that is at a lower level. So that is called a crater. The reasons for the high frequency of crater is the interdental area is the most common area for the deposition of plaque, and it is difficult to clean. So it is the very first area which is involved for any bone destruction. So in normally we have a flat or even concave surface of the interradicular bone in case of lower molars, which have that is a normal appearance, and then you have a crater which leads to concavity in the interradicular bone. The next anomaly is bulbous bone contours. They are bony enlargements caused by exostosis, and secondly adaptation to function, as we already discussed in trauma from occlusion. For the repair work we have buttressing bone formation. They are more in case of maxilla than mandible. Now the next anomaly is reversed architecture. Usually if you see the scalloping, basically the architecture of bone is that interradicular bone is at a higher level than the facial or the lingual plates. But when due to the resorption of bone, the interradicular bone or the interdental septa is at a lower level, rather than the facial and the lingual plate, we will see a reverse architecture. Usually it is concave. When there is a reverse architecture, it becomes convex. That means the facial plate or a lingual plate is at a higher level than the interradicular or the interdental area. Ledges. The next entity is ledges. Ledges are plateau-like bone margins caused by resorption of thickened bony plates. Now, if there is a thickness, okay, of a facial plate or a lingual plate, and you see a crestal bone is lost, and as you go down, the width of bone increases. So superficially or the coronally, you will see the bone is entirely lost, and as you go down, because of the thickness, you will see that there is a ledge formation at the margin. So that is called ledges. Now the next entity is furcation involvement. What is furcation? Furcation is a refers to invasion of bifurcation and the trifurcation of the multi-rooted teeth. That is called furcation. Now mandibular first molars are the most common site, and maxillary premolar are the least common site for the furcation involvement. There are various gradings of furcation involvement. In a grade 1, there is a very incipient bone loss, but the entire furcation area is covered by gingiva. Then you have a grade 2 furcation involvement, where there is a partial bone loss of the interradicular bone. The bone between the two roots is called interradicular bone. So there is a early loss of bone. Your probe, when you are inserting there, you can see it is going inside the furcation, but still this area is not exposed to the outer environment. It is covered with gingiva. And then you have a grade 3 furcation, where there is total bone loss of the interradicular bone. What does that mean? That means once you put your probe into the interradicular area or the furcation area, it passes through and through. Let's say you are putting your probe from the buccal surface, it should come out through the lingual surface, but still this area is covered with gingiva, right? And then certain times this area you might get confused is filled with a granulation tissue. So even if you try to put your probe, it doesn't come out from the other end. So in such cases, what you have to do is you have to insert your probe from the buccal side and measure the length. Let's say it is 5 mm, and then you are inserting your probe from the lingual side. There also, let's say you have a depth of 5 mm. So that means from both the sides there is 5 mm. If they are like equal to the buccolingual width of the tooth, that means the entire furcation is involved. If it is lesser than that, that means there might be a slight portion of interradicular bone is yet to be there. So that is falls under grade 2, not in a grade 3. Grade 4, it is very much similar to grade 3, where there is interradicular bone is completely lost, but with gingival recession. Up till now, there was no exposure of the furcation into the oral cavity. But in grade 4, now there is exposure into the oral cavity. Now, in microscopically, you can simply say that it is a phase of rootward extension of periodontal pocket. In its early stage, there is widening of periodontal ligament space with the cellular and fluid exudates. Now, the extension of inflammation into the bone leads to bone resorption and reduction in the height. Bone destruction pattern may produce horizontal or angular, and very frequently crater develop in interradicular areas. So thank you for today. That was regarding the bone loss patterns. Thank you so much.